Good afternoon, everyone. Respected judges and friends. The topic of the day is the binocular battle, a novel approach combining trans PRK and ICL for spectacle freedom. Introduction, as you know, the common refractive errors are myopia, astigmatism, and hyperopia. To relieve of these defects, you have spectacle correction, contact lens, then you got LASIK, laser, then ICL or the intraocular polymer contact lenses. This is a short video of photorefractive keratectomy, PRK. After topical application of anesthetic drops, you would do a trans PRK examer laser, put mitomycin, thorough wash, put a contact lens. That ends the procedure, PRK. So this is a surface ablation procedure suitable for thin corneas, avoids flap-related issues. Only problem is little of pain is there, delayed recovery and possible haze. It is irreversible. Then next comes the implantable columnar lenses. A short video there. How this ICL is placed inside the cartridge. Then the procedure, temporal incision. Under tropical anesthesia, this is performed. Side port incision. You implant the intraocular lenses. Then keep the haptics behind the iris. Here the posterior FP82 IOL, highly effective in eye myopia. This is suitable for thin corneas also. It gives an excellent optical quality and reversible procedure. Risk of cataract, IOP, raise and vaulting are certain issues. Ideal for candidates unsuitable for corneal surgeries. I just went to the literature where there was a comparison between PRK and ICL, but I didn't get any literature or papers in the past. The objective of the study was to evaluate visual outcomes, safety, and the patient satisfaction in patients undergoing PRK in one eye and ICL implantation in the fellow eye, the same patient. The aim was to compare visual acuity outcomes of PRK and ICL in the same patient to assess refractive stability, safety, and complications, to evaluate patient comfort and binocular satisfaction. The study design was retrospective, observational case study. Study area was in cornea and refractive surgery department at Tertiary Eye Care Center. Sample size was 5 patients, 10 eyes. Here, 5 patients who underwent ICL implantation for high myopia, unsuitable corneal parameters in one eye, and trans PRK for low to moderate myopia with suitable corneal parameters in the fellow eye. Data collection, postoperative uncorrected corrected distal visual acuity, best corrected visual acuity, refractive stability, contrast sensitivity, complications, and subjective satisfaction. They analyzed at first week, first month, 3 months, 6 months, and 1 year. By selecting contralateral eyes of the same patient, the study aimed to minimize inter-individual variability and allow direct comparison of outcomes under identical systemic, genetic, and lifestyle conditions. Patient selection, the inclusion criteria, as I said, age is 25 to 40 years, stable refractive area for at least 1 year, eye myopia not fully suitable for bilateral corneal refractive surgery, educate anterior chamber depth more than 2.8 millimeters for ICL implantation, healthy corneal endothelium with adequate endothelial count, absence of ocular pathology like keratoconus, glaucoma, and retinal diseases. Exclusion criteria include previous ocular surgery, active ocular inflammation, or dry eye disease, systemic disease affecting wound healing like uncontrolled diabetes and autoimmune disorders. These are the pre-operative evaluation which are done: visual acuity assessment, anterior segment evaluation, posterior segment evaluation, corneal mapping, anterior chamber analysis, and dry eye evaluation. Surgical procedures I already explained the video. Postoperative follow-up was in the form of first week, first month, 3 months, and 1 year postoperatively. Here it was in the visual outcomes, uncorrected visual acuity, best corrected visual acuity, manifest refraction, contrast sensitivity was analyzed. The stability, the refractive error change, how stable it was. The complication include the IOP examination, the slit lamp examination, fundus evaluation, corneal length, anterior segment evaluation, visual comfort, night vision, overall satisfaction, whether there was glares or halos and dryness was also evaluated. These are outcome measures. Primary, the visual acuity. Then second, you have got comfort of the patient, post-operative complication, contrast sensitivity, and corneal endothelial health. The results. The visual acuity, and in the LASIK PRK group, we had a slower recovery. Visual acuity between 618 and 69 in the first week, improved to 69 by 1 month, first month. By 3 months, we had a visual acuity of 6 by 6 in these eyes. In the ICL group, we had rapid visual recovery, 6 by 9 in all eyes by 3 to 5 days, stable 6 by 6 in 1 week. This is a comparison of visual outcomes. If you can see the decimal visual acuity, the top of the graph is 6 by 6, the bottom of the graph is 6 by 6, 6 by 60. Top of the graph is 6 by 6. The visual acuity in the form of a graph. Next, in the contrast sensitivity, mild reduction in contrast sensitivity in the first 3 months, especially in eyes with the transient haze. Glares and halos for more than 3 months, particularly in dim light. Symptoms decrease over time, but persisted mildly in one patient at 12 months in the LASIK group, LASIK PRK group. In the ICL, superior contrast sensitivity, especially under mesopic and low high light conditions in all follow-up visits. This is a graph. Bar chart showing night glare and halo severity. Pain in the LASIK group, moderate to severe pain and photophobia and tearing for the first 2 to 3 days post-operatively. In the ICL group, we had largely painless with only one mild foreign body sensation. Binocular and patient experience. Here in the early post-operative phase, disparity in visual recovery caused a temporary binocular imbalance in PRK group. From 1 month onwards, binocular function restored was normalized. By 12 months, all patients reported comfortable binocular vision, with some noting better night vision and clarity in the ICL eye. Complications in the LASIK group, one eye developed mild grade and one eye is at 3 months, resolved with topical steroids. In the ICL group, no cataract pigment dispersion was there, no cataract seen or raised IOP noted. Vault was well adequate in all cases. Discussion, as I said, ICL clearly outperformed the PRK in terms of speed of recovery. Patients exhibit better visual function. ICL provided superior contrast sensitivity throughout the follow-up. PRK had significant early post-operative discomfort, a major limiting factor for patient satisfaction. Binocularity in the ICL group, in the early mismatch between eyes, fast recovery, ICL and slow power PRK led to temporary binocular imbalance. The safety profile. Summary, ICL positives. Positive points are faster visual recovery, superior contrast sensitivity, greater patient comfort. Early glare, negatives were early glare, procedure initials, high cost. PRK group, positives were few optical side effects, compared long-term outcome. Negatives were slower visual recovery and initial pain, and of course, greater patient comfort. When used judicially in the same patient, they complement each other and expand refractive surgical outcomes. Combined techniques offers a space, safe, effective, and customized solutions for patients desiring spectacle freedom when LASIK or bilateral PRK is not feasible or bilateral corneal procedures are contraindicated. These are my references.
Did you do PI in all cases of ICL, sir? Yeah,
No.
PI?
No.
You have not done.
We have not done.
If I remember, you selected in the same patient for different eligibility criteria. So would that have contributed to any difference in the outcomes? Because of eligibility, like one were relatively shorter myopes and the other were relatively longer myopes.
Ah.
So the eligibility criteria differed in selecting the eyes within the same patient.
Yes.
So would that have any bearing on the outcome of the results? Preoperative factors.
Because certain parameters we can't stick to a certain parameters because we
sir.
need such patients,
Yeah.
The cost factor is also there. When you ask for a ICL in a patient who has done a PRK in one eye, the cost is it may become 3 times the cost, 3 or 4 times also sometimes.
Okay.
So the parameters, as I said, the corner parameters and other things we are set a protocol. Based on that, we proceed.
Okay, sir.
Sir, good presentation, sir. And what was the test for binocular vision which was done in this, sir? And was accommodation tested in all the patients before the surgery?
Basic protocols were done actually. All the basic protocols were carried on.
Because when we see the patients post LASIK, not related to this study, but generally when we see patients post LASIK, we find many myopes tend to have poor accommodation. So that may be one more reason for poor patient outcome and happiness post surgery. So that also.